already, and I'll just start I'll keep admitting as I start this off. But good morning, everybody. Welcome
Morning.
to this Ask the Doctor Zoom discussion with Dr. Jeffrey Zonder. I think you all know me by now. I'm Michelle McWilliams, Mickey, and I work with Sid Moss, Sid Wave from Cure Multiple Myeloma. And as I said before, put your devices on mute if you can, if you're not going to speak. We will be asking you to unmute to ask questions, but the background noise gets kind of in the way. We're so pleased to have Dr. Zonder with us today, Professor of Oncology at Karmanos Cancer Institute and MMRC Center, Wayne State University School of Medicine. Dr. Zonder's special interest is in multidisciplinary care of patients with multiple myeloma and the investigation of therapies for multiple myeloma. Before we begin our discussion, I'd like to thank our very important partners, Oncopeptides, Karyopharm Therapeutics, Sanofi, Bristol Myers Squibb, Adaptive Biotechnologies, Amgen, and Dova Pharmaceuticals. Without them, we wouldn't have the resources to reach out to patients and provide this great discussion platform. I also want to acknowledge Sid, the founder of Cure Multiple Myeloma. Sid and his organizations are responsible for the breakfast snacks that I kind of messed up on. This time there's this like fine line of time that I can order these, because if I order them too soon, you get them way in advance. And I can't switch the time, the date. If I order them too late, then they don't come. And this time I found some pancake mix that I thought would be nice with flavored maple syrups, and tried to order that, and I got, so some of you got that, but then I got to, somehow they said you're at your limit, so I couldn't order any more of those, which I thought was weird. And so some others of you have gotten the dried fruit. And then a few of you are getting that today, because I don't know why, but some of you that live in Northville are getting them today. And if you live in Bloomfield, you got them yesterday. So I apologize for that. You'll be enjoying your breakfast snacks for lunch, I guess. But anyway, thank you, Sid, for those, even if I kind of screwed it up a little bit. So just like the other discussions, the way this will work is Dr. Zonder will provide us with a little background on himself. Then he'll give us an update on treatments and any other news as it relates to multiple myeloma. Then we'll open up to questions from you. Please use the chat button to type in a question anytime during this discussion. I'll read all questions sent to me in advance and from the chat. Plus, we'll unmute and just take questions from the floor. And please feel free to unmute and just ask questions. That way it's a conversation instead of, you're not just hearing me ask the questions. It's much more interesting when you all get involved. So again, thank you for taking the time for the Zoom session. Take it away, Dr. Zonder.
Hi, everybody. I'm, as Mickey told you, I'm Jeff Zonder. I work at the Karmanos Cancer Institute. I apologize for being masked up even on Zoom, but I'm doing this from clinic, and rules are rules, and so we're masked up right now. I'm doing this from an exam room, actually. Today there's a lot of potential ground to cover. Just looking at the sponsors for this program, we could talk about recent drug approvals related to products that our sponsors make or are associated with. I always find it a little bit difficult, even in a room full of patients who I can all see. It's always difficult to have a canned lecture or a planned presentation that meets everybody's needs. And so what I honestly, I usually like to lead with questions. I like to let the participants tell me what they want to talk about, and then we'll talk about it. Unless nobody has a question or nobody has anything specific that they were wondering about. But I always, like I said, I always find that we are more likely to meet people's needs if I just let you tell me what your needs are today, and then we'll chat about it. Um, my I'll just, my for background, I run the multidisciplinary team for multiple myeloma and amyloidosis at the Karmanos Cancer Institute. That's a team of hematologists, bone marrow transplant and cellular therapy specialists, cardiologists, nephrologists, radiologists, pathologists, and we have a weekly meeting on Fridays to discuss new cases, um, and to discuss complicated management situations. We also have partners in the preclinical space at Karmanos, um, PhDs or MD PhDs who specialize in research using cell lines or animal models focused on multiple myeloma, amyloidosis, and lymphoma. So, having said all that, um, I, I guess I want to know what people want to talk about. I see Hal Anderson jumped right in with a chat question. What is keeping us from having individualized therapy? Uh-huh. Okay. Well, count on Hal Anderson not to throw me a softball, because that isn't a softball. That's a tough question. But Hal, I will do my best. And people can also just chime in, unmute and ask questions too, although the chat's fine. So, individualized therapy is a, you know, is a tricky term. I would argue that every patient in our clinic and in most clinics gets individualized therapy, in the sense that you're taking into consideration uh, uh, disease biology, uh, concurrent medical conditions, and patient preferences whenever you make a medical decision. And in the very increasingly crowded multiple myeloma field, where there are so many um, drugs available, and even multiple recent approvals in the last year, there are a lot of choices. um, Hal, I suspect what you're asking really about is precision medicine, or um, biomarker or molecularly driven treatment decisions. And the answer is finding key targets, and also having the optimal drugs to treat those targets. Myeloma is not a one-hit disease. Even after you divvy it up according to cytogenetic subtypes, each cytogenetic subtype isn't a one-hit disease. So what I mean by that is, let's take the example of CML, chronic myeloid leukemia. That's a disease where, until later in the disease, there is a single driving mutation called the Philadelphia chromosome. It's a fusion protein between two proteins on different molecules, BCR and ABL, and when that fusion happens, that single hit is enough to cause the disease, and treating that single hit is enough to shut down the disease. And so drugs like imatinib, um, ponatinib, there's a number of different drugs. There's multiple generations of tyrosine kinase inhibitors that target BCR-ABL now. And when you target that, that's enough to control the disease and put patients in molecular remission. There's no equivalent to that in multiple myeloma. There's no single driving molecular abnormality that accounts for most or all of the biology in myeloma that we've identified yet. And so we're chipping away at it. So right now, as an example of precision medicine, the MMRC is doing a Multiple Myeloma Research Consortium is doing a trial called My Drug, which is a targeted precision medicine trial. But what it does is it does a molecular profiling of each patient, and then based on the molecular profile, if there's a targetable abnormality, what we do is we add a drug that targets that abnormality to a general backbone of therapy, which is pomalidomide, ixazomib, and dexamethasone in this trial. So it's precision medicine, but just the mere fact that you're adding it to a general backbone tells us that we know that there's more than just the biology related to that target in play. And so, we're getting there. There are examples of drugs and abnormalities that seem to have seem to be particularly good targets. Um, so, for instance, there is a drug that is not approved for myeloma yet called venetoclax, and venetoclax inhibits something called BCL2, and that is most relevant in patients who have an 11-14 translocation in their myeloma. And if you look at the trials that have been done, the response rates to that drug in patients who lack that abnormality is very, very low. And when you use the drug in patients who have that abnormality, it's actually a very, very impressive activity, even in heavily pretreated patients. And the drug, again, combines with more standard backbone drugs. So I think that's an example of precision medicine or individualized treatment. We don't, in my own practice, when we use that drug off label, we're only right now using it in patients who have that translocation. If they don't have it, we wouldn't even think about offering that drug. Now, hopefully, we'll find other ways to use the drug, or we'll find ways to broaden the target or the applicability of it. Sometimes you can get synergy with other drugs, and we're planning to study that in the very near future, a venetoclax protocol in combination with other drugs. And we have some evidence that it might extend the efficacy of that drug based on what happens in cell lines and mouse models. So we'll updates to follow as they become available.
So I see that we've got other questions in the chat, and I put one in too that came from me on an email just a few minutes ago too.
Okay.
Do you want me to read one, or do you want to read it, or how do you want to do this?
I can read it.
Okay.
The one you posted at 8:12.
Yep, I just posted that one, and then there's others.
So this question is from Jerry Oth. In the latest IMF publication, Myeloma Today, on page 7, there's an article about the role of mass spec or mass spectrometry that says this simple blood test may soon replace standard serum protein electrophoresis fixation for diagnostic and monitoring purposes. It can more accurately tell the difference between very low levels of myeloma protein and monoclonal protein such as Darzalex, and that a more sensitive version of this simple blood test can be used for determining complete remission and MRD status in place of bone marrow biopsies. Has this more sensitive test been approved for use, and it is now being used for this purpose, and has it been approved for reimbursement by insurance companies such as Medicare? So this is a test that right now is being done at Mayo Clinic. Mass spec is a general technique where it allows for sensitive identification and characterization of proteins. And it does, one of its uses absolutely is going to be overcoming the idea of therapeutic interference. In the question, the writer alluded to the fact that sometimes after a patient has had a great response to antibody-containing therapy, and that could be Darzalex or the daratumumab, that could be isatuximab, that could be elotuzumab. theoretically, that could be belantamab. But these are, uh, what on protein electrophoresis, um, uh, the test has a difficult time telling the difference between an IgG kappa M spike and an IgG kappa therapeutic antibody. Both of them will register in a similar way on the test. So sometimes after a patient has had a great response to therapy, when their baseline marker is IgG kappa, sometimes what happens with ongoing therapy is the M protein has actually disappeared, and what you're picking up is the antibody, and it still registers as an IgG kappa, and you don't know if that patient's in complete remission or not until or unless you do a bone marrow biopsy. Um, and the way mass spec works is that um, these two different proteins would register differently on the test. And so you can absolutely tell the difference between two different IgG kappa antibodies if based on their structure. They have a different profile on this test. And it is more sensitive than serum protein electrophoresis with immunofixation. And there's interest in using it as a substitute, for determining complete remission uh, and MRD positivity or negativity. I think though, you know, MRD testing is an example of where the definition of complete remission starts getting blurry. We actually, we have a response category called complete remission, and then we have another category called stringent complete remission. The first one doesn't demand that the light chains ever normalize. The second one does demand that the light chains normalize. And then we have MRD positivity and negativity. And it turns out that even with extremely good regimens, um, half the patients, or a third to a half of the patients who we think are completely free of measurable disease still have measurable disease when you use MRD testing. So if you're MRD positive, are you really in remission? I mean, that's the, it's these, when we say complete remission, when we're using the International Myeloma Working Group's definition of complete remission, stringent complete remission, these are holdover definitions. These don't reflect actual biology. They have definitions, and knowing what the definitions are is important so that when you're talking about the complete remission rate for a study conducted in 2021, you're talking about the same thing that was used in a study that was done in 2017. You're not raising the bar in terms of what constitutes a complete remission, and making it, you know, putting newer studies at a kind of a relative disadvantage by demanding, by using more sensitive testing to determine if they're in complete response or not. But uh, uh, I would say this is a work in progress. I do think this is coming. I don't know if this is reimbursable. I know that it is orderable at the Mayo Clinic. I don't know if it's reimbursed. It's not a test that we routinely use at this point yet in standard practice, except for amyloidosis. I use it for typing amyloidosis, but I don't use it for measuring minimal residual disease. Right now, I use the adaptive clonoSEQ test for minimal residual disease, which is a bone marrow biopsy test. And there are, liquid biopsy, blood-based MRD tests in development that everybody is super interested in the idea of a blood-based test. But right now, the approved one, and the one that most people are using, is the commercial clonoSEQ test, unless they have an in-house MRD test available to them.
We have a couple more questions in the chat.
Yep, from Robert Brooks.
Yep.
With development of new techniques, when will we be able to speak about multiple myeloma having cures versus no cure, which often scares early diagnosed patients beyond the desire to fight the disease? I think that we're entering an era where there are going to be patients who are functionally cured. Again, definitions matter. And I think there is a difference between, being able to have some sort of finite therapy that puts disease in remission and it stays in remission without ongoing therapy versus disease that you can control for 10 or 15 or 18 years with ongoing maintenance therapy. It's you know I, both of those would be huge success stories in myeloma compared to history, but those are different things. um, right now, we're getting closer to that second scenario when we have numerous examples of patients in our practice, and even on this call, without naming people, who are able to have good disease control for 10, 15, or 20 or more years. Um, we have I saw a patient this week who's gotten more than 8 years of disease control from her first line of therapy. So it's not, um, you know, um, outcomes are improving on an ongoing basis. Um, I think, though, there are going to be some patients. I think we're entering, I think what we see on the near horizon is with MRD testing. I think we're going to find some patients who are rendered MRD negative, minimal residual disease negative, with some period of finite therapy, and who probably can take a break from therapy and coast, and that period of coasting will also be measured in years for some patients. And if that process starts when you're 78 years old, then there is some very real possibility that you get finite treatment for a few years and then coast, and you live your life. I mean, so I mean, I think we have now, and we will be seeing an increasing number of patients in that sort of scenario. So that patient, whether, whether they would relapse if they lived another, 12 years is, a question. But, if they don't relapse in the first 8 and live their lives out, then they're functionally cured, right? So I do think we're going to see a subset of patients who are actually cured, in that respect. Uh, from Stephen Hall. My opinion of obtaining second opinions from myeloma specialists. Is it possible for 2 myeloma specialists to work together for a more informed therapy? Um, I guess it obviously depends on the myeloma specialists. I, you know, I think that there's utility to seeing somebody who focuses on a specific disease, on your disease. So I have a biased opinion on the need to come see, a myeloma specialist, or especially an amyloidosis specialist. Um, you know, Being evaluated at a transplant center, I think, is important. Um, for many, most patients probably. Um, my philosophy about second opinions is everybody's entitled to it. There's often utility to it, and I personally don't have ego issues about second opinions. I don't. It doesn't bother me if a patient seeks an opinion from me and goes back to their first doctor. It also doesn't bother me if they want to be seen at a you know some other nationally recognized center to get further input. Um, we I have a lot of patients who spend their summers with me and their winters in Florida or Arizona. um, I work with and I work with somebody at Moffitt or Mayo Scottsdale, or UT Southwestern, all of those places. So and the short answer is yeah. I mean, generally speaking, we can work together. um, it's also, the myeloma community is not, we all know each other too. I mean, so I feel like my job, when a patient comes to me and I render an opinion and they say, okay, I'd like to get a second opinion, I try to give them good guidance about, maybe where to go. So, in the state of Michigan, there are a limited number of places that represent something similar to the Kermanos program in terms of myeloma. But there are programs. But I mean, if you're going to go within Michigan, it doesn't make sense to go to a place that sees 1/10 the amount of myeloma we see. I think it makes sense to go to one of the other, myeloma focused practices with people who have actual expertise in the area. And if and likewise, I routinely help patients connect with colleagues regionally and nationally if they want to do that, because it's easy to help. It's easy for me to connect somebody, or Chicago or Harbor or Mayo. It's really easy. So I try to help when I can. Uh, Question from Diana: what is a COVID-19 antibodies spike test? Should we be seeking this out? Oh, and then I see right below that Hal Anderson has lost sound. Are you back, Hal? With
Yep.
sound?
Yeah.
Good. All right, good. All right. So Diana, this is a great question, what you're asking about COVID-19 antibodies and anti-S antibodies. So the vaccines generate an antibody response to the S protein on COVID, the spike protein, and it's very specific. So when you're vaccinated, if you respond to the vaccine, you should have measurable titer to anti-S protein. The original COVID IgG and IgM antibody testing that everybody was getting to see if they had been previously infected wasn't looking at the S protein. And so the general test you would order in an urgent care, to look for COVID antibodies, don't measure the antibodies that you get from the vaccine. It's a little bit like the antibody profile after you've been vaccinated for hepatitis B versus if you've had a hepatitis B infection. So you have antibodies against the hepatitis B, one of the surface antigens, only if you've been vaccinated, but you don't have antibodies against like core antigens and things like that. You only develop those antibodies if you've actually had a hepatitis B infection. So there's a difference in your antibody profile if you've been infected versus if you've been vaccinated. And the same is true with COVID. Short answer is it's the antibody test you need to see if you've had a response to the COVID vaccine. And with regards to myeloma patients, the emerging data that's coming out is that a significant percentage of myeloma patients don't have a great anti-S protein antibody titer after being vaccinated. And people are becoming aware of this data, right? This is in chat rooms. This is being discussed online on myeloma news sites and things like that. And so I'm getting asked this all the time, and I think I probably get asked 3 or 4 times a week if I'll test anti-S protein antibodies. There is a commercially available test, but right now the guidance is that we don't know how to use it. We don't know if a little bit of a bump is enough. We don't know how long anti-S antibodies actually last. So we don't, even if I tested you this week and you had antibodies, that doesn't mean that 4 months from now or 6 months from now or 10 months from now, you'll necessarily have the same titer. And the current guidance, unless the president updated it yesterday with his press announcement, which I didn't see, and so I'm going to just acknowledge that I may not be up to date in the last 24 hours about guidance, but right now as far as I know, the CDC is not recommending doing anti-S protein antibody levels on immunocompromised patients or other people who've gotten vaccinated. And the reason is we don't really know what to do with the results, and the titer may be a moving target over time, and so the snapshot that we get from the test may not be helpful in sort of guiding behavior. And the case rate right now in the community is so high that even having an antibody level that gives you 90% protection or whatever, 95% protection may not be enough to prevent you from actually catching anything when there's so many cases out there. And so, right now, I mean, what am I doing? I'm in an exam room in a clinic with the door shut, and I'm going to be in this room later with somebody else, and I'm wearing a mask. I mean, we're still masking up, and we're still, inside. We should still be taking some precautions. I guess outside we're loosening up precautions a little bit as of yesterday if you're vaccinated. I'm not sure that recommendation um, necessarily extends to immunocompromised people, knowing what we know about the anti-S protein levels. So my recommendation to patients is to still be very careful. Certainly to still be very careful out in the community, out in the environment, until case rates come down. Once the case rates come down, that's a little bit different, I think. Okay. Um, Another not easy question from Hal Anderson. Thank you, Hal. Usually you plant friendlies in the audience. No, this is from Hal. With all the alternatives available now, does having an autologous stem cell transplant still make sense? Right now, the best evidence we have is that there are still patients that benefit from transplant. There are several lines of evidence about this, but there's also an increasing amount of evidence that the timing of transplant may not matter as much as we used to think it did. So we know, for instance, from the IFM 2009 study, which was the French half of the study that Dana-Farber has been heading up on this side of the Atlantic Ocean. What's it called? I guess it's the determination study. But it's basically it's a randomized trial comparing RVD induction, and then stem cells get collected, and then half the people in the trial get a transplant right then, followed by a little bit more RVD and then Rev maintenance. And in the other arm, the experimental arm in this study, they just get more RVD all the way through the time until the same time, equivalent time as the other side is finishing up their RVD, and then they go on to Revlimid maintenance. So everybody ends up getting about 9 months of therapy, but in one arm, 3 of those months is basically the transplant and the recovery from the transplant, and then some consolidation. But it's 9 months of induction with or without a transplant in there, followed by maintenance. And what we saw was that the complete response rate was a little bit higher when you had transplant. The MRD negativity rate was a little higher when you had transplant. The progression-free survival was a little bit higher when you had transplant. And so overall, there were, less patients in the transplant arm in the first analysis of this study. Less patients in the transplant arm had progressed on to second line therapy, after the first 3 years. So probably that has to do with that MRD, the depth of response that we were seeing, that more patients got to deeper response. And that was true regardless of how you measured MRD. Different MRD tests have different sensitivity, and what it showed was that not only did more patients achieve MRD negativity, just the absolute number of patients who achieved MRD negativity using, how do I want to put this? Using the less sensitive test, there were more patients who became MRD negative with transplant, but also when you looked at those MRD negative patients, with, when you took those patients who were called MRD negative using the less sensitive test that was originally used, and then you applied a more sensitive MRD test, it turns out that not only there were more patients who are MRD negative using the first test, but of those patients, more of them were also negative using the more sensitive test, a higher percentage of them. So there were some patients who, using a less sensitive MRD technique, were called negative, but when you used a more sensitive technique, they actually weren't negative. And that mattered. It turns out that if using the more sensitive test, you were still positive, it was as if you were just positive. Um, so So that's kind of a long roundabout answer saying that transplant does improve depth of response. And so, to me, the idea of, if you can delay that what's next question, what's plan B when we relapse, if that conversation happens 2 years later or 3 years later because you used better first line therapy, you are, what the options you're talking about in that conversation are likely to be better. And so I do feel like there's still a role for transplant in suitable patients. Now, having said that, that same study just had an 8-year follow-up at ASH this year. And what it showed absolutely was that when you looked at the two arms, far more patients in the non-transplant arm needed second line therapy. And almost all of those patients got transplant as their second line therapy. And so really functionally what we were comparing was transplant as part of first line therapy versus transplant as part of second line therapy, right? That's really what the study is looking at. And it turns out that after 8 years of follow-up on average, there's no difference in survival still between the two groups. And so, it's, depending, you can use that data to support or refute the need for transplant, in my opinion, right? I mean, it's, if all you're interested in is survival, then there'll be no difference in your survival on average, your odds of being alive, if you have transplant available to you and use it as part of first or second line therapy. Okay. If it were me, I would rather be sitting there at 8 years only having had one line of therapy than having had 2 lines of therapy. So, I feel like the survival is a wash, but the length of disease control still favors transplant early. And so I absolutely favor continuing to use transplant. There may be therapies coming that change that, right? So bispecific antibodies, CAR Ts, there's a lot of stuff that's right here that, may alter the playing field completely. But for now, I think transplant still has a role. Okay. Next question was from Mr. Gorash, and it was a question, if we can scroll back up here for a second. Significance of having both kappa and lambda characteristics, and how does that impact the prognosis and ability to achieve response to therapy? Not sure I quite understand kappa and lambda characteristics, but I guess just to explain kappa and lambda and light chains, plasma cells, every plasma cell makes antibodies that have either a kappa light chain or a lambda light chain. And when you have a clone of plasma cells, like in multiple myeloma, you generally have that clone makes all the antibodies are of the same type. So that's when I say like an IgG kappa myeloma, what I mean is that all of the M protein antibody that those myeloma cells make are IgG antibodies with kappa light chains, and that'll register as a spike on serum protein electrophoresis with immunofixation. Most patients only have one or the other. Occasionally, patients can have biclonal disease, this is like a 1%er. This is, this is a very, very small subset of patients. Um, and the the significance of recognizing more than one clone is just making sure that you're following everything that needs to be followed. But being biclonal doesn't fundamentally change the way that we treat the myeloma. Okay. From Diane Lack, IgA kappa myeloma, transplant in 2019, on Velcade since transplant, presumably because of this 414 translocation that you mentioned. My last labs showed significantly increased kappa and lambda levels, but still within normal limits. Is that, well, that, I'm not sure I understand that. So were the levels both elevated, but the ratio was within normal limits, Diane? Can you unmute and just say it? Diane on?
Yes, to unmute. I'm asking her to unmute.
Okay, yeah. What was your question?
It was your question. Yeah. So it showed, my last lab showed significantly increased kappa and lambda levels, but still within normal limits. Did you mean the ratio was within normal limits?
Yeah, the ratio is normal, but the levels had been low since transplant, like really low, and had been stable. And then all of a sudden they had a jump with my last labs. And, I'm just concerned about that.
Are they still within the normal range, each of them?
But still within the normal range, yeah.
Yeah, I don't think that, I mean, if they're rising proportionately and if they're rising proportionately and they're still in the normal range, that's probably nothing to worry about, honestly. You know, it is possible that the COVID vaccination stimulated the immune system a little bit, and it's possible that you got a little bit of a bump in your light chains or antibody levels in general.
Yeah.
But it's also possible, I mean, there is gradual immune reconstitution as people get farther and farther away from transplants. Their immune system comes back online, and it doesn't come back online all at once. May of 2019 is a little bit out. So, I mean, my guess is something you're probably responding to something, whether it's the vaccine or something else. But if they're going up together, that's probably the explanation. I mean, the other thing is if there's been any change in your kidney function recently, because if your kidney function is depressed even a little bit, it could result in the light chains going up. Light chains are filtered through the kidneys. And so like if the kidneys aren't working quite as well, it's like the drain being backed up a little bit. You don't have to turn up the water to have the level rise in the sink if the drain's backed up, right? The water could be running the way it normally does, and you still raise the level, right? And that's antibody production and light chain production specifically is sort of like that. I mean, your bone marrow may be making the same number of light chains, but if your kidney function took a little bit of a hit from anything, for any reason at all, that could make the levels go up.
Okay, great. Thank you.
Mhm. Okay.
I have a question.
Okay.
This was, I did a survey of patients to find out what they felt was important to, for us to concentrate on. And one of the things in the survey results that patients felt was really important was staying healthy during treatment, including dealing with diet and physical exercise. So can you speak to diet and exercise? What things are important maybe to avoid both, in diet and exercise, and what is important to include?
Well, again, that's a very individualized thing, and the exercise question specifically does I think is always, my recommendations are always in the context of somebody's skeletal disease, like what kinds of exercise are reasonable and what kinds aren't. Um, you know, I, um, I generally recommend avoiding weights, heavy weights. I have a lot of patients that use, 5 or 10 or 15 pound, dumbbells and do stuff, like this. But I do generally recommend that patients avoid, like, a classic one is like loading their shoulders with a bar, like putting weight on your shoulders and doing squats or shoulder presses, like things that put excessive amounts of pressure on your hips, or on your low back, to me are, probably things to be avoided when you have osteoporosis, osteopenia, bone lesions, in the spine. You don't want to, cause a compression fracture. And so, those kinds of activities we limit. The activities that are a constant haggle with everybody are golf, skiing. They want to know, can I do the, can I do these activities that I truly love doing, um, but which pose some degree of risk. And it's like I said, it's a haggle. It's always how do you, because I encourage people to be active. And I think it's good to exercise. I think that, I mean, I have a patient that after a couple of years of negotiations, I mean, we we had like a a customized approach to him going skiing every winter, where we would like modify his dose of blood thinners and and make sure his labs were okay and get imaging before he left, and I mean, like that sort of thing. I mean, we would, and and he's, and he would avoid the hardest hills that he used to go on in moguls and try not to fall. And that was his plan for the winter. Right. And, so I mean, full contact sports, sports where you can fall. I mean, things like that, you know, I try to focus on aerobic type exercise, muscle toning exercise, low impact stuff that isn't going to jar your back too much. Um, I'm more of a fan of stationary bikes than outside biking, but I'm probably projecting my own insecurities about falling off of a bicycle. If you're a good bicyclist, you can probably bicycle. Swimming, as long as you're not, deeply immunocompromised, like immediately post transplant or something like that. Swimming is a great activity. Um, ellipticals are probably better than treadmills. I mean, things like that. Now diet. You know, um, Diet's tricky. Um, I mean, ideally, everybody should be eating a healthy diet. Um, my honest, time we talk about diet a lot is right after diagnosis. Patients often want to know, it's a common question. What can I do differently? What have I been eating that's been contributing? What should I be doing to improve my nutritional status? I, my I'm cautious about that, to be honest. I mean, I'm always happy to refer to a dietitian. My feeling is that, like, I, like many people in the United States, have struggled with weight. As we get older, it's increasingly hard to find time to exercise your way to ideal body weight. So there's always calorie counting or carb counting or something to maintain weight for most of us, unless you're just one of those people who manages to not overeat. But most of us overeat. Um, and I actually, I always recommend sort of, um, caution about changing your diet heavily right after a diagnosis, or right when we're starting a new regimen. The therapies that we use, many of them have GI side effects, which can range from, you know, um, you know, poor appetite or nausea, with certain drugs, to diarrhea as a very common side effect of some very commonly used medications. Um, taste sensation can be altered by many different therapies that we use in myeloma. And, to be honest, sometimes it's hard to even eat the stuff you like eating when you're starting treatment. And so I'm reluctant to tell people, we're going to start this 3-drug combination regimen that may have these GI side effects, and I want you to not eat food that you consider to be the food you enjoy eating. Like I want you to struggle with a diet at the same time. And so you know, I tend to work with people more gradually about diet, and I try to dissuade people from doing massive overhauls on their diet as they're starting therapy until they find out what the therapy actually means for their appetite and for their GI, symptoms in general. Okay.
Makes sense.
That said, I'm going to, before we move on to this next question about quality of life, that said, I suspect that 75% of my patients are on different kinds of supplements. And so I do try to make it my business to know something about, alternative medicine and supplements, supplemental, products, because patients ask. And so, if I had this conversation yesterday with a patient I had, who's taking green tea, and has been drinking green tea, and to get significant, to get like any kind of measurable levels of the key ingredients in green tea, the green tea catechins, you have to drink like a gallon of tea a day. So I just pointed out that you could get that with a green tea EGCG supplemental pill. And, when you bring that up, you have to know the dose, right? So I talk about EGCG and turmeric, resveratrol. I mean, these are things that patients, ask about. And so I have a lot of patients on a lot of these agents. And there are certain situations where you want to avoid them, but I acknowledge and accept the fact that patients are using them.
I was told a long time ago not to drink green tea because it affects your chemo. Now I don't know if that still stands.
Yeah, Diana, I just said, as I was careful about my wording just now, because I said there are certain circumstances, and you're right. Green tea and Velcade is one of the ones you want to avoid. Absolutely. There's a chemical interaction between EGCG and bortezomib, and so that is one situation. So like that patient before who mentioned she was on bortezomib maintenance therapy, I would not want her taking green tea supplement along with that. Yeah, you're right. Good memory. All right. Next question. We typically discuss improved therapies. Are there any studies looking at quality of life issues? There are. Quality of life issues are increasingly built into every large study being conducted in myeloma. It's a major part of drug development now, and especially in the sort of like Me Too era of drug development, where it's like, it's a second generation version of this drug, and then you have a third generation version of this drug, and then you have an oral fourth generation drug version of this drug, and they're all very closely related. They're very closely related compounds with very similar mechanisms of activity. And hopefully, a lot of times the difference between a first and second and third and fourth generation drug is is target specificity. It's still hitting the same target, but is it only hitting that target? And is it hitting that target harder? Is it hitting it more permanently? Is it, or more irreversibly? And so one of the ways that pharmaceutical companies are looking at the question of, how are these drugs different from each other? And how does it matter if you're hitting the target more cleanly or less cleanly, more irreversibly, less irreversibly? If you're using a different treatment schedule with the same drug, they're looking at quality of life. They're looking at side effects. And so like side effect reporting, patient reported outcomes, super, super common. And so we, most of the large trials we open up now, come with a like a tablet that we have in clinic, and patients are answering surveys, every cycle or every 3 cycles, things like that. Yeah, yeah. So yes, I mean, quality of life is a humongous focus, and so is diet. So is diet. We're yeah, we're looking at right now. I'm working with one of our fellows. We're developing a protocol, a pilot study where we're using a commonly used calorie counting app to track dietary intake for patients on treatment. And we're sort of the pilot, we're looking at like, frequency of reporting, the duration of the ask, like how long are you having the patients do it for? How does that affect compliance? Because we want to see if we can use these commonly used tools that everybody has on their phones already. Can we apply them to medical, obtaining medical information? And we're not alone in that. I mean, most of us have heard how, Apple Watches and Fitbits and things like that are being used to do vitals monitoring and activity monitoring. So it's, increasingly common strategy.
So
Okay.
I have another question,
Yeah.
and this has been brought up at a couple of our different sessions.
Yeah.
I would like to have a way that everyone that goes to our website or comes to these sessions can find out about any new trials that are
Yeah.
coming about. Is there any way that I can be able to post anything new, or some way that I can disseminate information to patients about something like that they may want to participate in?
Yeah, so there are a number of sites that have developed or are developing trial matching tools. Myeloma Crowd has something like that. The the Amyloidosis Research Consortium has something like that for amyloid studies. I mean, you can also go to clinicaltrials.gov, and if you're interested in a specific drug, you can search for studies using that drug, and then you can click on each trial and find out where it's being done. Also, most cancer centers have postings about their clinical trials. Like you can find out what clinical trials Kermanos has open easily. So there are multiple tools, multiple sites that are trying to do exactly that.
So if I just go about putting
If-
links to all those places on my site, that might be helpful.
Right. If you'd like, I can help you identify some sites that we could put on a site that's, like a hub.
That's what I'd like to do. I think that would be helpful to patients if I had
Yeah.
a place where they could just go and see what's available.
Yeah.
Thank you. Thanks.
Clinicaltrials.gov is a great way. If there's a drug that you're interested in, if you're interested in a specific CAR T cell, if you're interested in, a specific, if you're interested in trials involving, melflufen or iberdomide or selinexor or eltanexor, or I mean, if there's a specific drug that you're interested in, and I'm just rattling off ones that some of your sponsors, like that's how I picked, I'm staring at the background behind you, your virtual background, and I'm just rattling off products from from our sponsors. But but if you were interested in those agents, then you could go on clinicaltrials.gov, enter the agent, and you would be able to find trials. Some of them, there will be a handful of trials, and some of them, there will, I mean, if you type in selinexor, I don't know how many trials there will be, but it will be probably measured in dozens. And if you typed in carfilzomib, right, it'll be an entirely different, thing. And there'll be hundreds of trials involving carfilzomib that are open right now because it's an approved drug being used in combination with other things. So, it may not, clinicaltrials.gov is a list of all registered trials being conducted in the United States right now. So it's comprehensive, but it may not be efficient if you're looking for a drug that's open in hundreds of studies. You can also search by site, though. You can enter in keywords and things like that. And so it's still a good place to look. That's always my starting place for patients.
Where do you look for Carmonas' trials?
I can find the link for you. There's I can find a link. There used to be, I'll be honest, I haven't used it in a while, but there used to be an app. There used to be a clinical trials app, and I don't know if that's fallen by the wayside or not, but it was a periodically updated phone app that showed you what was open.
Okay, if you give me the name of that, that'd be great.
So what I'll do is I'll follow up with Dr. Zonder and Dr. Zonder's team and see if I can get those things posted on our website, and I'll provide everyone with links to that.
Okay.
So we are past our hour now, and I know Dr. Zonder is masked up and ready to see patients. So I don't want to take up too much more of your time, but I thank you so much for all this valuable information. This is really important. I feel it's important for everyone here, and I learn a lot with this too. So I really thank you for that. And also I want to mention to all the patients here, if you want to be on our task force, our patient task force, please just send me an email and say, sign me up. I want to be on the task force. We're going to come up with a date and time for a Zoom, so that I can get an idea about what is important to all our patients too. So with that, thank you, Dr. Zonder, so much for this. And I think that we've got to let you go now because it's
nice to see everybody. Nice to see familiar faces.
Thank you. Thank you.
Hopefully we'll be able to have the fundraiser this fall.
Yeah,
right? We'll see.
Yeah, we're looking at it. We're hoping that we can. We're going to wait for a little while to see right what's happening in the world, and especially in Michigan, and then we'll make sure that everybody knows what's going on.
Okay, thank you, Dr. Zonder.
Thanks, everyone.
Thank you.
Thanks a lot, Doc.
Have a good day, everyone.
Bye.
You too.